Here I am performing Thompson's test to confirm my findings. There is also palpable gap in between the tendons. Now patient is placed in prone position. We take around 7 to 10 centimeter incision. I usually take it more on medial side than bang on posteriorly. I deepen the incision till peritoneum, try to preserve the peritoneum, whereas in this case the peritoneum is also torn. I don't want to go beyond peritoneums because I don't want to inadvertently damage the nerve which is there on the lateral side of the incision. And now you can see that the torn portion is degenerated and it is layered also. I will try to preserve as much tendon as normal tendon as possible. Because of the large gap, we have decided to go ahead with FHL transfer. I have to prepare the bony area for the FHL tenodesis. So I take out some superficial bones. Subchondral bones must be preserved. Once it is done, I want to find the FHL. So I take incision on the fascia below the TA. I want to be more careful in finding the tendon. So my aim is to find the muscle belly and not the tendon, because there are neurovascular structure lying just anteromedial to these structures. Once I find the tendon, I plantar flex the foot as much as possible and try to cut the tendon as deep as possible. Then the Krakow stitches are taken with a number 2 ethibond and the tendon is prepared. A tendon is usually less than 6 mm and it is usually more than 4.5 mm. So I want to drill a hole of around 6 mm. Now I am drilling first with the guide wire or a B-spin at the footprint that I have prepared and drill that bone with the help of 6 mm drill bit. You can take help of C-arm as well. Once it is done, then sutures are passed to the B-spin and are retrieved from the heel. The tendon is passed in the tunnel. Now the foot is placed in 30 degrees of plantar flexion and the screw of appropriate size, usually 20 by 6 mm, is passed into the tunnel over the tendon. This is how the tenodesis is done. Now we usually check the stability of the fixation by pulling the tendons. I use non-absorbable stitch in the tendo Achilles. Try to take it as distal as possible and stitch it with the tendon of FHL. Many times it is not possible to stitch it with the tendon, but I'll at least make sure that at least 1 or 2 stitches are in the tendon. Many people also use Vicryl for this purpose. It is also advisable to preserve peritoneum as much as possible. It was however possible in this case, so I am closing peritoneum over the repaired area. In the whole procedure, we make sure that we are not putting much pressure on the skin edges, because it is a very delicate area and can easily go on necrosis. Once peritoneum is closed, we try to take loose sutures on the subcutaneous tissue. I never use staples for the skin sutures. I usually take Ethylon 30. I use simple stitches or I use Donati stitches so that there is minimal stress on the skin. Non-adhesive dressing is done, and once it is done, foot is placed in 30 degree of plantar flexion and BK slab is given. I usually give a below knee slab for 4 weeks and keep patients non-wet bedding for 6 weeks. Gradual range of motion is started only after 4 weeks.